take that?
You want to think about success for barbell medicine? I'll take the stuff.
Yeah.
Cool. Yeah. So our careers are indeed very unique, and we are like insanely busy all the time with a number of projects in the air simultaneously at any given time, constantly throwing ideas back and forth at each other of things we want to be doing. And so in addition to our regular medical practice work, coaching people in person, programming folks online, but really the common theme among all of it is kind of helping people get to either a healthier state of, a better state of health, typically in the medical side of things. We're coaching people in person, particularly the most rewarding people to coach in person are the older, more frail folks for me. Because I remember I've had a number of older folks in their 60s, 70s, 80s, like, you know, came here because I started to notice myself getting weaker, taking these little shortcuts in my day-to-day life, so I wouldn't have to do these difficult things and stuff like that. So get them started training. 3 months later, they come back, they're tripled their strength or something like that. And they're like, everything's easy now, I feel great, stuff like that. So that's super rewarding. And then when we do a lot of programming for high-level lifters, and seeing a lot of their success when they go out and compete and do great things is really satisfying too. So you can see there's kind of a common denominator, and we get a lot of variety working with these vastly different populations. You know, I mentioned earlier some of the patients I see and treat in the hospital and the ICUs. That's like as far down that like sick realm, side of things as you can, all the way to the other end of like elite level, you know, national level strength athletes and stuff like that. So that's, for me, like one of my favorite things is being able to see, treat, manage people across this whole spectrum, from like the person who's like dying like now to the person who's like a total freak about to kick ass at some like, you know, high level competition or something like that. It's super satisfying to be able to have that skill set and apply it and, you know, have people do well.
I just like being on Instagram mostly. Well, okay, so I'll answer this in parts. The most rewarding thing for me, easily, is being able to have a big sphere of influence, particularly on the professional community. And my professional community is fairly widespread, including physicians, other healthcare providers, and then coaches. So I get to influence a lot of them, and that's the most rewarding for me, because I feel like, you know, I can treat one patient, I can treat, you know, over the course of an entire career, thousands of patients, but if I can influence thousands of providers or professionals, then that sphere of influence grows to tens, 20s, hundreds of thousands of people, which is cool, right? As far as the long-term, sort of like what does success look like for barbell medicine, I want barbell training to be the new walking. So when your doctor, for all their, you know, misgivings at the end of the visit, when they say, you know, just do some more barbell training. That's what I want. You know, this whole thing started from pretty humble beginnings. You know, I was my first business was educating trainers at this large personal training company in St. Louis. And then when I went off to medical school, and I'd been coaching people like full time, and I went off to medical school, I started this company, Barbell Medicine. I'll just do some remote consultations for nutrition, training, stuff like that. And then throughout medical school, it became apparent to me that there needed to be some sort of driving force behind bridging the gap from strength and conditioning to medicine. And, you know, once we linked up, we kind of were on the same page, and we're like, we're gonna do something with this. We don't know what does it look like, don't know yet. We'll just put out we'll keep writing articles, we'll keep working with more and more people, we'll keep doing seminars, you know, with Starting Strength, and we'll try to grow this thing and see what happens. Well, earlier this year, we got an opportunity through Up to Date, which is basically the doctor's Google, and they want us to write the article on benefits of strength training on health. Like, which is effectively gonna turn into an encyclopedia, you know, but we're like, well, this is where it starts. That's awesome, you know? And I think that's just the start of how we end up making barbell training the new just walk more. And that for me, that's what success looks like. I mean, I don't know, you know, doing the Instagram live stuff's cool, being able to meet a bunch of different people, different seminars, it's awesome. Helping individuals, super rewarding. But, you know, I'll know that I'll have made a big enough impact on the world once that happens. And that'll be cool.
We'll do it.
Yeah, just squat more. It's fine. Can you imagine?
Yeah.
Crazy. So
I was there for deep tissue. any of that type of stuff is like completely out the window, or would you at least give those things some credibility in that scope?
Okay, so this is a deep
Don't be triggered.
topic.
Don't
Yeah.
get triggered. Don't
No,
be
no,
smug. You gotta talk loud. You gotta talk loud.
This is a deep topic. So the premise of your question, you said, we would all agree that training is the most important thing for chronic pain, which is itself is debatable because it is a component, exercise is a component of the process. But I don't think we have evidence to say it is the most important thing for all these people to do. In fact, there's some chronic pain syndromes where if you have them exercise or train too intensely in this hypersensitized, wound up individual, right, who's sensing benign stimuli and perceiving pain as a result, you could set them back a long ways, right, if you end up throwing them under the bar on the first day, right? So I would certainly not say, and I don't believe I did say, that the barbell is the only way to do this thing, because in fact, there are essentially no people out there treating chronic pain with barbell training. There are a very small handful of physical therapists who have kind of risen to the top in this community, who I know and have become friends with, who are also on the same page with this stuff, but it's a very small handful. And so exercise is important, but more importantly than that,
Not more interesting.
right, is getting to the root of the syndrome, right, which, as I discussed at length, is in the brain. So if I can find a way to lower the perceived threat level, right, their perception of fear, anxiety, if I can alter their expectations to get them to start moving through some of these ranges of motion, and to the extent that they have symptom fluctuation while moving through that range of motion, they get themselves to a point where they can interpret that symptom fluctuation as non-threatening, then I'm succeeding. Does that make sense? So in that context, you look at these passive modalities, and I remain unimpressed because I want them to be moving, increasing their confidence, lowering their perceived threat level. Now, let's say that you take them and you give them a massage, as I mentioned, those intense sensory experiences, or you do A.R.T. or this instrument massage stuff, these dramatic or novel interventions, high intensity sensory experiences, and they get a real potent placebo response out of it. Because again, I'm not at this point willing to credit most of these interventions with real tissue structural benefits, because the evidence suggests there isn't any. But to the extent that you get a neurophysiologic mechanism, if you want to use that phrase rather than placebo, that then facilitates them starting to move through these ranges of motion and lowering their perceived threat level, then I'm okay with it. However, the thing to watch out for is, remember I talked about resilience, self-efficacy versus dependence, right? What I don't want is for them to say, I can't bend over and tie my shoes today because I haven't gotten my massage yet to release my fascial knots or whatever, right? So it's all couched in the language of how you talk to these patients. So if you tell them, we're gonna do a little bit of massage or mobilization or whatever, because it's gonna feel good, and then you're gonna start moving through these ranges of motion and we're gonna get you doing that, then I'm okay with that, actually. But if you tell them your pain is coming from made up structural issues, your fascial adhesions, and I need to release them before you can do this activity, we have a huge problem there. Does that make sense?
Yeah.
So that's my, and the idea is that those passive interventions are not to be maintained long term. It needs to be a short term intervention until you can get them doing what they need to do, build their confidence, resilience, right? And then they have their self-efficacy, and then you let them fly. That's what I would like to see.
So like the ultimate goal is still, to get under the bar, regardless.
Long term, that's what I would, that would be my bias, right? Other therapists have other opinions. They might say that there's no magic to barbell training versus other type of resistance training, and that's kind of a different debate for a different day. But I want them to be independent and doing this stuff without feeling like they need this stuff forever.
Yeah. It's like, I think everybody's heard of like the monthly chiro, the monthly, massage, the monthly this.
Yes, firmly against that.
Yeah.
Very firmly against that.
But it does have its place, but to facilitate getting back to training, getting back to your baseline.
Yes. And it would, but then the question becomes, more interestingly, right? You have this massive cornucopia of passive modalities you can apply to somebody. The majority of which essentially, as we said, function through this kind of placebo effect, facilitating reducing threat level. If they have a good rapport with the therapist, all that kind of stuff improves it rather than the structural stuff. So again, I'll go back to that language thing. But you have this huge number of choices. How do I decide which one I'm going to do with somebody? Am I going to do acupuncture? Am I going to do massage? Am I going to do Graston? Am I going to do cupping? And so it ends up in practice just being whatever modality the person that you're seeing happened to pay for and go to the seminar to go see. Does that make sense? So we don't have a strong way to choose which one we're going to do for somebody. So that's kind of another question is like, But if the person themselves has a preconceived expectation that one of these modalities is going to help them, and then the therapist meets them where they are and say, I agree, it might help you get back to activity, not I can help you and then see you in a week, and then see you in a week, and then see you in a week, then I'm okay with that.
But if the ultimate goal is to reduce pain and increase range of motion to perform their normal daily activities, then it's considered a benefit.
Yes.
Regardless if it's a placebo or there's some actual type of neurological benefit.
Right. Again, as long as it's not pursued forever, and you don't use language that ends up causing the nocebo type deals. You tell them it's because of this or that structural defect that you have, or you're broken, or your back's all out of line, or whatever. Cool.
Some low intensity steady state and or some HIIT, is that right?
It might. So it depends. So we have evidence to suggest that there is a base level of conditioning that needs to be attained to effectively eliminate any premature morbidity or mortality risk from not having that level of cardiorespiratory fitness. Okay, that can be measured as either VO2 max, all right, or metabolic equivalence. Those are the two sort of metrics that we use. There is a good portion of the population who, without any formal training, will have exceeded both of those minimums, and therefore would not require additional cardiovascular training specifically to improve those numbers. There's another portion of the population who would not meet those levels without any sort of training, but when undergoing resistance training, do meet those minimum levels, okay? And then there's a third population who, even with resistance training, do not meet those sort of minimum levels of cardiorespiratory fitness. And then those folks, I would advise to do aerobic exercise or high intensity interval training, or potentially both. So how do you know which one you're at? So the minimum threshold, and I believe this is for all age groups up until age 65, is that you can attain an output of 8 metabolic equivalents. And I don't know offhand what sort of activity is like 8 metabolic equivalents, but a quick Google search will tell somebody in the room what that is. But if you can do that thing right now, so what a flight of stairs is 4.5 metabolic equivalents, because that's the pre-op thing.
I think it's 4 or 5.
Yeah. So if you can climb, 3 flights.
Climb a flight of stairs with a bag of groceries in your hand.
Yeah. If you can climb, 2 or 3 flights of stairs with a bag of groceries in your hand and not feel like you're having a heart attack, then you can likely exceed that metabolic equivalent rate. And so you may not benefit from cardiovascular specific training at this time, outside of potentially weight loss, because your training volume goes up. Does that make sense?
Right, so to be clear, that threshold that he's talking about is the threshold below which, if you have less cardiovascular capacity, your mortality risk goes up. Your risk of certain diseases goes up.
Yep.
But that's one context here. The other context being some of the other things that we've talked about this weekend when we were talking about hypertension or obesity, insulin resistance, stuff like that. So there may be other reasons besides just that minimum threshold for mortality that you would still want to undertake that.
Yeah. So if you have any of the issues, or if somebody has any of the issues that we're talking about, so high blood pressure, elevated cholesterol, obesity, insulin resistant diabetes, stuff like that, I think I could make a pretty strong case for some conditioning, even if they are a novice, where classically you would hear that if you're a novice, don't do any conditioning. But I think at that point you are in fact a special snowflake, and then you require some special snowflake management. All right, which is fine, because the idea is that we're improving health, we're improving strength, we're improving quality of life, all that stuff. So But if you don't have any of those conditions that we talked about, and you can climb the 3 flights of stairs with a bag of groceries without feeling like there's an elephant sitting on your chest, then at that point I think you've earned yourself a bye for conditioning until you get to the intermediate stage. And at that point, the function of conditioning is either for a conditioning specific goal or to improve your recovery capacity so that you can deal with the volume, right?
So even then, it wouldn't necessarily be just for your overall health, it would help you with your.
Right. Yeah, because if you don't
Those
have
are some of the other contexts that you might think about this in, right?
Yeah, yeah. If you don't have any of the conditions we spoke about this weekend, and you can run up the 3 flights of stairs with a bag of groceries, and you're fine with that, then there's no benefit to doing the conditioning unless it directly contributes to your other goals or for personal enjoyment. If you're like, you know what, I don't care what that guy says, I like riding my bike, and I'm gonna ride my bike, damn it. Ride your bike, you know. But I wouldn't ride my bike here. It was terrible. How? You're like riding through a wall of moisture, just like the whole time.
During that process. Should it be barbell training or should it be variance?
So the question is on pregnancy and training. Is she training already?
I'm trying to get her to train.
Right, yeah. Should refer out for that.
Fully.
Refer out for that. Unless you don't want to have a kid, in which case.
I coach this guy. I'll coach her.
Yeah. So if she, so here's the deal. There's no data on this. And what I mean by that is they haven't run like, this group of pregnant women who started training on their first trimester, here were the complications, if any, here compared to the people who didn't train. All right. That being said, what's interestingly happened the last 3 years is that the American College of Obstetrics and Gynecology, which is where all of the recommendations for pregnant women and OBGYN related issues, that's where all the recommendations come from. They took out the idea that resistance training was off the table. They said, you can do resistance training, that's cool. The general rule of thumb is if you were doing it prior to becoming pregnant, you can continue to do it. I would take a harder stance and say, if you want to start resistance training, that's fine. We just don't know if there's anything bad that's going to happen from it. We don't have evidence that shows that it does, and there's some safety studies that have shown no increased complication rate or morbidity, sort of like a disease, or certainly no mortality increase or other pregnancy-related complications. So we know that that doesn't necessarily increase with resistance training. But we haven't been studying this stuff that excessively for that long. So my recommendation would be have Austin train her now, and she should train through pregnancy. As an anecdotal report, my friend Mike, his wife recently just gave birth. She pulled a PR triple on a deadlift, although it's sumo, so it doesn't count. But I believe it was 365 for a triple 2 days prior to delivering. And he says that it took her 5 push-ups. So just a heavy set of 5 to get the baby. What's
She had the strength of a woman plus the strength of a woman.
Right, she was lifting with 2, so it's really cheating. Double cheating.
Yeah.
Double cheating. Plus sumo, so basically the weight was negative. I don't know if the baby's back was rounded.
I'm pretty sure the baby's back was rounded.
So I guess the obvious answer though would be if like, say the belly's hitting the at that point, just variance your squat.
She might sumo. She'd probably be able to squat just fine.
Yep.
Yeah, I mean, it's going to be one of those, you're going to be putting out fires. Now my back hurts, so maybe you don't squat that day, or you do. I mean,
And I remember, I think it was, she's had 40 kids or something, I don't know.
The entire population of Westminster,
her and
Maryland.
Yeah, right. So I remember one thing she specifically commented on is noticing that as she kind of progressed along, because of the anatomic changes of pregnancy, your center of mass moves, your balance changes, so it actually changed some of the mechanics of her lifts, and so she found that actually like squatting in heels in her weightlifting shoes actually became an issue, and so she actually ended up doing better in flats towards the end of her pregnancy, and just kind of more like little anecdotal interesting things that you have to watch out for. Yep.
Yeah, if you Google hard enough, you'll find different recommendations from like the NSCA and ACSM and American Council on Exercise, so ACE and all these other NASM, all this stuff. It's all junk. None of it's evidence-based. It's consensus-based by people who obviously don't know how to train people because they're parts of these organizations, right? So similarly, you're going to find on a CrossFit journal or something, there's going to be articles written by a CrossFitter who's had a kid, right? And while I don't think that they're bad to expose your wife to because they may encourage her to actually train, you have to understand that, you know, nobody should be recommending doing burpees and, you know, these other things. And it's not because I think they're directly injurious to the growing baby or mom, but it's risk-benefit. Risk-benefit. So
Do you have to be
there's
doing burpees?
there's a potential risk that maybe this does increase risk of something bad happening. And doing burpees as a pregnant woman, what benefit does that have for you outside of this sort of self-realization that you are an independent woman who don't need no man? And I'm not here to decide that. I'm just saying that it's not improving your fitness, and I'd rather see you squat, bench, deadlift, press, you know, plus or minus the power clean, chin, stuff like that. I think that has a much greater benefit much better risk-benefit profile than any sort of metabolic conditioning workout you could do. Or if you really just want to do conditioning, which is probably assault bike intervals.
Growler bike, you know.
That's fine, but what's the purpose? What is the purpose of doing overhead squats and burpees if you're 9 months in? I don't know, other than to get your picture on the front of the website. Commitment.
The website.
It's more histrionic.
More history on it.
More histrionic. That's the next thing.
All right.